All right. In the interest of time, I guess we'll get started. We appreciate everybody being here. I know we're up against Sono games, so it's hard. I imagine that people have some conflicts or want to support their residencies. So I'm Seth Lotterman. I'm one of the assistant program directors at the University of Connecticut. Work in the emergency department at Hartford Hospital, and my colleague is here with me.
I'm Dave Ruby. I'm also one of the attendings that works at Hartford Hospital. I'm the director of emergency medicine simulation for SESI, which is the Sim Center at Hartford Hospital.
And so we're going to talk to you guys about resuscitation leadership, what your emergency medicine residents are lacking, and how to fix it. So real quick before we start, I appreciate everybody being here. I just want to, for those of you who have learned, who have done resuscitations, I just want to think about how you learned how to run a resuscitation. You know, was this like, did you have any formal training in this? Or was it like mine, and like a lot of people where you kind of learned on the job and maybe you got some good tips, you got some not so great tips, you kind of figured things out as you went along and, you know, got to the point we are now. So the goal of our talk is to kind of go over a little bit of what the current literature is on this and, you know, what are, you know, kind of the background for this and what's out there. Our goal is to, really big goal is to help people develop their own leadership training styles, you know, whether it's kind of a sim session or kind of other stuff that you can use out there. That's kind of our big takeaway, hopefully. And then once you develop that, how to kind of evaluate that and kind of make sure that people are taking away the right stuff from your training sessions. So why this is important, right? So we've kind of, this is actually our program director and two of our senior residents. I think we're pretty sure he always matches somebody who looks like, who is bald. It's a body double. But I think this picture illustrates sometimes what happens in a room when a resuscitation comes in and you're kind of there's a lot of who's in charge and who's gonna run this right now. Is it the resident, the attending, which I think is a conflict that I often have in for our work right now, or Dave and I work right now. There's occasionally times where it's a trauma, and is it the trauma attending, the ED attending, who's making the final decisions? And then other places, when you go to the community, is it, you know, sometimes it's hard when you're kind of new at a place and you don't know people very well, and you're kind of trying to kind of get the lay of the land and run a room and, you know, take good care of your patients, but also, you know, how do you kind of do the people skills part of interacting with people and run the resuscitation without kind of, you know, being either too bossy or like too passive. So what we do at our program, kind of what we developed for us, is we kind of have a two-pronged approach for this. And like many places, we have graded responsibility for our residents. And the beginning of second year, our residents spend the first conference day going through our resuscitation bays and learning where everything is and kind of getting a feel for the, you know, kind of how to do all that stuff at our primary site. And we have 18 residents a class, and so it's a pretty crowded session to go through. And when COVID hit, we kind of had to change things a little bit because we were like, we can't fit everybody in the rooms as it is, and we have COVID restrictions for numbers and stuff like that, so we need to do something with half the class. And this is a silver lining of COVID was I had been thinking about this for a while and wanted to run a session where we kind of, taught them how to run a resuscitation, kind of really went into the leadership part of this. And so this gave us the opportunity to kind of break the class in half and run like a sim session, demonstrate and really model the behavior of how to run the resuscitations. The other thing I want to mention real quick is just, this is kind of part of the hidden curriculum of medicine a little bit. You know, we, kind of the things that we maybe aren't intentionally teaching or don't realize we're teaching, but we teach it, kind of the culture of the program might teach this. So I think with resuscitation leadership, you know, this can kind of cut both ways. You can have a really good culture and you can see people who are doing a great job and you might learn the right things, or you might have a poor culture and not really learn the right things and have some issues. And hopefully by bringing this out of the hidden curriculum into a more formalized structure, you're then able to kind of, you know, kind of adjust that and help people get on a better approach to this. What's out there? So, you know, as someone who, we did a study on this, it's very hard to do these studies. They're very time intensive, resource intensive. So there's not a lot of data out there, but a couple of studies that have shown some promise. This one looked at trauma activations, and in this study they took second and third year EM and surgery residents. They divided them in two groups. The randomization group got more formal training, didactic, sim session, and leadership, and the other group got their usual training. And then they actually videoed all their traumas, and they went through and looked at everybody who had, and they kind of went through the trauma videos and looked at their leadership skills as well as the outcomes of patients. And so from a leadership skill standpoint, there was a very clear difference, and the group that had the intervention had clearly had better outcomes. in terms of leadership stuff, but they didn't have the clinical outcome was much harder to show, so there's a little trend there, but not anything that was statistically significant. This is another example looking at medical resuscitation, so this is ACLS. And again, in this scenario, the groups that had better leadership skills performed higher quality CPR, better technical performance, they had shorter pre-shock pauses, lower total hands-off ratio, and shorter time to first shock, right? And so we know that these are the things that are gonna give our patients the best outcomes. So even though it's really hard to show that you're gonna make a difference in a scenario with cardiac arrest, because it's just the outcomes are so poor in general, and it's hard to show like maybe a small difference, but we know that if you run it better, you're gonna have a better chance of having better outcomes. You're gonna do the right stuff for the patients in the right time quickly. This is just a kind of qualitative study looking at what people think about when they kind of think about learning and teaching on resuscitation. So kind of the big things I took away from this were there are several major themes, and kind of in terms of in terms of training. And so there are ways, the methods they used for leadership training were reflection, feedback, right, hands-on learning, which we kind of realized. Simulation is another big one. Group reflection, didactic, and the one that I kind of really had been thinking about was role modeling, right? So actually demonstrating those behaviors for people. Like, how do you know what good resuscitation looks like if you've never seen it before? And so that was really the goal of my part of this, was to really kind of be able to demonstrate good resuscitation leadership skills. And then if you kind of look at early learners versus advanced learners, the early learners want more supervision and guidance, they want more feedback. As you progress, you want more autonomy, so the advanced learners kind of need a little more autonomy and hands-off part of this. So what we did for our residents as they came in, we actually had various iterations of this. Initially, we actually brought in a couple of attendings to run these. I would do a simulation session with them, and the residents would watch them do a sim, and they would kind of see the ideal skill sets and how an ideal resuscitation can be run. Again, that's kind of labor intensive, so what we ended up doing was we videotaped a couple of our senior residents running resuscitations that they had scripted out and showed those to the senior residents. And so they had these scripted scenarios. They did an example of a well-run and an example of a poorly run resuscitation session. They wrote, the residents wrote all these out. They had a very nice scripted session here. And I'll actually show you a little video clip of what the ideal one looked like.
I see some ST elevations in the anterolateral leads. It looks like he has this patient is at a STEMI right now. What was your name again?
I'm Ryan.
Ryan.
Is here.
Nice to meet you, Ryan. I'm Dr. Takumi. I'm one of the residents here.
Sure.
So we have a patient here who's coming by EMS in about several minutes out. It looks like the patient has a STEMI.
Sure.
So immediately when he gets here, are you able to establish ID? Get one at least 18 gauge if you can in his AC or anywhere.
Sure.
After that, can you immediately place him on the monitor as well? We need blood pressure, pulse, pulse ox, and whatnot. Okay.
Sure.
And also send some rainbow lamps for him as well.
Cool.
And after that, can you just verbalize what you're doing and tell me so I can give you further direction after that?
Sounds great. We'll do.
Okay. Do you have any questions at all?
Nope. Not
Okay.
Right, and so that's kind of the ideal leadership right there, introducing themselves, very calm, collected, discussing, having a shared mental model of what's going to happen and making sure there's no issues, and kind of the setting up for like closed loop feedback of like, let me know what you're going to do and what's going on, so we kind of are all on the same page throughout the resuscitation process. So that's like the ideal, right? That's what we want to have, how we want to have it go. This was a trauma that the residents wrote out, and this is the less than ideal, probably to the extreme version of resuscitation.
Just me and you can handle this. Yeah, I don't think we need anyone else in
Okay.
here in the room. I guess once he gets in here, I need you to get just 2 large bore IVs. I need you to get central line kit, A-line kit. I need you to get pressure fluid bags going. I need you to get some uncross matched blood ready. I need you to also talk to the blood bank about possibility of massive transfusion protocol. I also want you to get all the labs you can, rainbow draw, and I want you to also don't get anyone else's help. They're super slammed in there, so just your priorities, getting all that stuff done as quickly as humanly possible.
And for the record, both residents know that this was being presented here today, and they gave permission. But you can kind of see, like, this was, tax saturation, overwhelmed, didn't ask for help, just, it was going to go poorly. So that was the first day of kind of the beginning of second year, which is the part that I would run. And then I'm going to turn over to Dr. Ruby now, and he does a session a little bit later in the year that we look at it, that they get to kind of do some simulation work with.
So what we ended up doing from the simulation side was we developed a leadership day for SIM and put it into our curriculum. And this day's been around since about 2017. It was developed by myself and my co-fellows. And ultimately, while we do focus on the critical care aspect of it, a lot of this day is focused on, as Seth said, the sort of the hidden curriculum and how to actually command a room when things are getting a little crazy. So we wanted to make sure we delivered both those kinds of material to the residents. We rotated them through 4 different cases, and the rule for the day is they have to switch the team leader each time. Nobody can do it twice. As far as the cases that we did, we did 2 cardiac arrests, one with a shockable rhythm, one with a non-shockable rhythm. We did a severe GI bleed, and we also did a respiratory distress, which has an actor in the room that is the respiratory therapist who is purposefully uncooperative and requires constant redirection. And this sort of allowed 4 different kinds of leadership scenarios where it would be significantly important for the resident to be able to command that room while still delivering the critical care topics that they should be getting used to at this point. And as a reminder, this day was for the second years. And we usually give this day sometime in the late fall, early winter, when they've sort of settled into being second years and are starting to be relied upon to run things a little bit more. When each case is done, we do a debriefing in the room. And the debriefing does go over some of the medical aspects of what they've done, but they also, the big focus is on the leadership aspects and sort of getting an idea from the residents, all of them, but especially the one that was the leader in that case, how they decided to command that room, what challenges they encountered, and how they decided to approach them. And the residents sort of ended up discussing it amongst themselves. And as with most debriefs, the instructors sort of guide the conversation during it instead of spoon-feeding them the answers to things. And this allows the residents to have a productive discussion and ultimately self-discover the learning points that we wanted to get across. And we've always found at the Sim Center that leads to better retention of those learning points. So, and then, this is a video clip or just a picture?
Sorry.
Let's see.
That should just play.
Most comfortable, but let's assign some roles. Okay. Do you want to record? That's an important
Sure,
job.
I can record.
Yeah. Huh? Okay. Do you want to do history and physical, and you be in charge of procedures? Okay. Get ready to tube.
So Lizzie, you're the team leader. Tell me how. Give me a rundown.
I mean, I think we had a good plan. We had roles assigned ahead of time. I think aside from our technical difficulties, I think everyone worked well together. We had someone on procedures. We had, once they had to start compressions, we had someone else on airway, and then, I think we kind of went through our list of what we thought was going on, and everyone kind of contributed ideas. Yeah.
Okay.
I thought it was okay.
So, notice that I don't want to run down of this medically because this is a case that you guys should know how to handle medically. But all of you should know how to run a shockable code by now. The hard part is actually making it happen. And I hope this illustrates for you the difference between knowing it and doing it.
So we just wanted to play a little bit of the, that's the second day, kind of the residents kind of preparing themselves and kind of setting up their their leadership, what they're going to run during their resuscitation, and then a little bit of the feedback part of that, kind of going over, how this, the feedback that Dr. Ruby gives to them and the other instructors, kind of how they debrief on the leadership part of that. So I think as you put stuff like this into practice, you want to evaluate things and make sure you're getting, that residents are learning the right stuff. And so the feedback and debriefing is really helpful after the simulation sessions. This is an area that I think on shift too, it's a little hard to kind of think about this sometimes, but when you're in a room where the resuscitation, I think as an attending especially, even a senior resident sometimes, when you have the time to, when you're not the person running the resuscitation, you have the time to kind of like look at stuff and figure things out and kind of observe, you can kind of say, hey, I want to give you some feedback on how this went. Here's what I thought you did well, I want you to be better at this and improve, and here's the things I thought you did really well, here's some things I think you can work on in terms of commanding the room and making sure people understand who's in charge. There's some scoring tools and stuff like that, which I'll show an example of as well. This is what we used for our study when we kind of looked at this and we graded our assessments. It just gives you some kind of milestones and set points of like what, poorly done, poor behavior, appropriate, and like really good behavior kind of looks like, so you have something to kind of help people with. The other thing I will just leave as kind of a future thing with this is I'm not a huge video game person, but I got my kids an Oculus a couple years ago, and having played some of those things, like the role-playing games in there are very, it feels very intense and like somebody's right next to you. And I could kind of see scenarios where you kind of set up develop a sim session like this and have the, resident can do this on their own time at home on an Oculus or some other, VR device, and I have no disclosures and affiliations with that or anything like that, so. But they could run a session like this kind of on their own and practice it and rehearse it and, get some feedback and then kind of go do it again and stuff like that, so. With that, happy to answer any questions and thank everybody for being here. And references. Yeah.
Do you give, after these sessions, do you give your faculty any kind of guides in terms of when giving feedback for resuscitations in the future? You kind of talked about how it's a bit of a hidden curriculum to make it a bit more structured.
We haven't given faculty anything in the department to kind of go over. I'll let Dr. Ruby kind of talk about how he runs for his sim sessions, though.
Right, so for the sim sessions, there is a guide in terms of the debriefing, and what we usually do, since the vast majority of sim cases in the curriculum that I run are performed by either a sim-trained attending or one of the attendings that is maybe not formally trained but does sim a lot with us, they've gotten fairly good at the debriefing, so at the end of each written case for these, there are a list of debriefing points that we try to hit. That being said, if you have experience in sim, you know that doesn't always happen and depends on how the case actually goes. You might have 4 very different cases each time. But we do try and hit some of the core points of it on the debrief to make sure that everybody gets at least some degree of uniform education with this. So in that regard, we do have a bit of a guide for them. But that being said, also each of us has our own debriefing style as well. So that's about as far as we give them in the Sim Center.
Thanks.